Before we get started, I just wanted to mention David Brailer, who was the President's Health IT Czar before this last one. He used to go around and talk, and he would always talk about two things having to do with health information technology. He would always talk about interoperability, do the systems talk to each other, and then the adoption gap. And it's always occurred to me that we really have to kind of crack the nut of interoperability before we're really going to get the adoption gap. In order to have interoperability, there are technology standards so that systems have to be able to talk to each other. And for those of you who don't know or don't follow this, there's been a recent sort of activity that I've been very encouraged about, and that is in the consumer home market, consumer IT standards for equipment we use at home. There's something called Continua Health Alliance, and it was led by Intel, but all of the major provider groups and vendors are at the table, and they have a process in place so that in probably 18 months, I think, we'll have IT standards in the home consumer environment. And so that's kind of like the camel nose under the tent, and so hopefully then just the snowball will roll, and it won't be too long before our systems can actually communicate. So as I always say, it's not about the technology, it's about the people. So you're going to get to hear from some great people who deal with technology every day. We have 5 panelists. We're going to start with Joe Koenig, who is the IT director for the State Department of Health and Senior Services. And Joe was very instrumental in the governor's Health Information Technology Task Force that we met over the last year. And he's going to kind of review some of the findings from that task force and kind of do an overview of what's going on in Missouri in terms of the current status. Then we're going to hear from Rachel Mutro, who's the Associate Executive Director for the Missouri Telehealth Network, and then Karen Thomas, who's the President of Oxford Healthcare in Springfield. Fourth, we're going to hear from Jim Hansen, who's the new CEO of Healthy Mid-America, which is the effort in Kansas City, and in some ways Kansas City is one of the leaders in the state in terms of these issues. And Rick Royer's going to bring up the end. He is the Chief Executive Officer of Primaris Healthcare in Columbia, which is really the statewide quality improvement organization for our state. So without further ado, I'll turn the floor over to you, Joe.
I think Dr. Young did a great job setting up for me. I think I'm in a unique position where I actually feel like I might be able to answer some of the issues he posed and answer some of the questions that were asked earlier. First and foremost, though, being from St. Louis area, Cardinals are up 3-1, so get that out of the way. As Karen mentioned, I was involved in the Governor's Healthcare Information Technology Task Force, which was created in January. Goal was to really address a couple of different issues: the siloed information that exists throughout the entire health system, the lack of data sharing among providers, and the limited ability for public health to do monitoring and surveillance of diseases as well as bioterrorism. There were a number of working groups that were created as a response to 6 different bullet points that were in the executive order from the governor. There was a current status working group, which was to look at what's happening right now in Missouri, as well as issues working group, which was looking at some of the technical issues as well as security, privacy. And one important point to note there is that Dr. Young brought up the issue about the privacy issues, the HIPAA issues, the laws that exist throughout the different states. There is a national contract right now where RTI, along with the National Governors Association, is looking at privacy practices throughout about 40 different states, looking at the laws, trying to identify variances so they can begin to work through those to develop a set of laws that will allow states to exchange data amongst each other. There's a cost evaluation working group, which was really just looking at, what is this going to cost to put something in place for the entire state. Resources working group, which Rick Royer was the lead on that group, which was to identify, what exists out there right now, public and private, that we can partner with to help pay for this. Telemedicine working group, which was Karen's group, and best practices working group to look at what have other states done, what does the state of Missouri need to be doing in order to get this accomplished. Current Status Group did a survey across the state. It was delivered to a couple thousand people through a number of associations and other partners that the department has, trying to find out what's currently happening. We looked at hospitals or systems of hospitals, healthcare provider offices, mental and behavioral health facilities, long-term care and skilled nursing facilities, and local public health agencies. All groups, to some degree, reported using some level of electronic health systems, which was encouraging. When you look at hospitals, there's a number of components that we broke these systems down into, probably about 20 different components that we were saying could comprise into an electronic health system. Hospitals mainly used laboratory information, patient registration, scheduling, radiology, and pharmacy. We did find that the rate of adoption in the state of Missouri is actually fairly low when you compare it to a national average. You look at telehealth, electronic health records, electronic medical record systems, e-prescribing, and laboratory information systems. Laboratory information systems was the one that was most often used by hospitals and healthcare provider offices, followed up by electronic health records, which includes a number of those components we talked about, the scheduling, billing, any of those. And there again, we've got the healthcare provider offices. Like I said, they're using clinical data, patient registration, scheduling, labs, and billing. What was interesting was that when you look at the hospitals and healthcare provider offices within the state that were using electronic health systems, about 2/3 of them, of the hospitals and half of the healthcare provider offices, had been using these systems for over 2 years. It's interesting that there seemed to be a break in there, that either they had been using it for 2 years, or they were just beginning to implement a system. There was very few in between there. There again, just the fact that there are some that are implementing still, but the biggest barrier right now seems to be financial support, as well as a lack of standards. Karen was mentioning standards. Right now, there really are no standards set up to help facilitate how this data is going to be exchanged among different systems. If I have a certain vendor and the hospital across the street has a different vendor, the data that comes out of our systems aren't going to be the same, and there's really not any set of standards right now to say this is how the data is going to be exchanged. We looked at a number of different activities throughout the state, just trying to identify some key activities that were going on. One is down in Bolivar, Missouri, which is in the southwest Missouri. They employ 1,500 staff. They're the sole community provider in that area. They received a $1.5 million grant from the Agency for Healthcare Research and Quality, which they used to fund Project InfoCare, which provided a electronic medical record for the entire facility. They also gave any independent physicians who, utilize services from Citizens Memorial have at least read access into the information to see, what other services their patients are receiving. It started in December of 2001. It's completed in December of 2005. It allowed Citizens Memorial to become completely paperless, which is a big deal these days. It's very rare that an electronic system will move you to a complete paperless. Just a brief note on the Missouri Telehealth Network. I'll leave that to the next panelist, who probably has a little more information on what's going on there, as well as Karen's obviously well versed in that. Someone had asked earlier about utilizing claims data as some sort of medical record. Blue Cross Blue Shield of Missouri actually has a pilot project in the St. Louis area that is doing exactly that. It provides that information to emergency room physicians. If a patient comes in and they're unresponsive, they have an insurance card on them, that physician or someone in that facility can log on to a website provided by Blue Cross Blue Shield and look at medical claim data for that patient. It includes let's see, includes pharmacy admission information, procedures, diagnosis. It's no cost to the facility. It's available even on previous Blue Cross Blue Shield patients as long as there is a signed consent form from the patient. It's, like I said, it's currently in St. Louis area. It is part of a larger project for all of Blue Cross Blue Shield. They've actually done some work up in the state of New York to integrate their claims information with a personal health record that WebMD is providing, so that you have the patient filling out their personal health record, but it's also auto-populating based on claims data that's coming in. We have Healthy Mid-America out in Kansas City, which I will leave up to Jim here, who's the CEO, newly named. BJC Healthcare has created a personal health record for their employees. It's called myhealthfolders.com. It works on a slightly different method, allows the user, the actual owner of that record, to print off a identification card to store in their wallet. So if something were to happen, a healthcare provider has access to go online and view that record. Obviously, there's a little bit of a security privacy issue there in that you lose your wallet, somebody could find it. In order to protect against that, they've limited it so that the ID on the card expires after one use. Card becomes invalid, the user would have to go on and print another one. Right now, that system is available only to BJC employees. They are hoping to open that up to other employers in the future. Goal of that is just like any other personal health record. They want the participant, the patient, to take a more active role in their own health care. Kansas City Regional Electronic Exchange, obviously an effort in the Kansas City area. When you look at the administrative overhead involved in health care, as the IOM stated, somewhere between 28 and 31 cents of every dollar spent goes to just administrative overhead. What KC-RE is trying to do is kind of become a middleman to help facilitate the exchange between the provider, the insurance company, and the bank of transferring the funds. The goal is obviously to cut down that administrative overhead, reduce the overall cost of health care. When you look at the system right now, each provider connects independently to the payers. So you end up with this whole big maze of all these connections going throughout the entire system versus, centralizing it to one spot. Right now it's currently St. Luke's Health System, Commerce Bank, and again Blue Cross Blue Shield out in the Kansas City area. It's based on a project that was done out in New England that actually realized somewhere around $20 million in 3 years. Kansas City area, they're hoping to realize somewhere around $7 million savings in a 3-year period just on that claims processing area. I believe that KC-RE and Cerner, Healthy Mid-America, have actually had a few initial discussions, see if there's any potential for a partnership there. They're pretty different projects, but it's just good that there's some dialogue happening there. Last one I want to highlight real quick is St. Louis Integrated Health Network. It's a primary care home initiative in St. Louis. If anybody's familiar with KC CareLink, it's out in the Kansas City area that links up the safety net providers to try to exchange data among those providers in order to improve the level of care that those patients are receiving. Similar process out in St. Louis. They want to increase the wellness and health literacy of the patients. They're working on right now a network master patient index, which will, again, just centralize the storage of the data for those patients who seem to travel between the critical access hospitals in the area. There is a task force final report. I mentioned that the Governor's Healthcare Task Force was delivered September 1st to the Governor. It is available on the Department of Health and Senior Services website. Highlights any of the recommendations as well as all the different reports of the working groups. Includes more information about the current status report that was given as well. Last thing, tonight, Game 5. Hopefully everybody's watching, so thank you very much.
Hello, Rachel Mitra up next.
Hi. Isn't that pretty? Nice in fall colors. Thank you for having me come and talk today. I'm happy to share some information about the Missouri Telehealth Network and a couple other things that I would like to share with everyone. Again, I'm Rachel Mutro with the Missouri Telehealth Network, and we are part of the School of Medicine at the University of Missouri in Columbia. Today I'm going to talk a little bit about telehealth and telemedicine and what that has to do with Missouri Telehealth Network, and then a new pilot program that the FCC has just come out with an order for. So, telehealth is the use of electronic information and telecommunications technologies to support long-distance clinical health care, patient and professional health-related education, public health, and health administration. And we provide direct patient care, consultations, education, and also a network that acts as a mechanism for disaster preparedness and response. But right now we're going to talk a little bit more about direct patient care. So we say, why telemedicine? And obviously we know that physicians are in short supply in many areas of the state and the country and the world, and we're going to emphasize rural. Many patients have significant barriers to accessing health care, again, in the rural areas for sure, and the technology is more affordable and better quality now. And for the rural populations in Missouri, nearly 1/3 of Missouri's population lives in rural areas. In comparison with urban Missourians, the residents have higher poverty rates, larger percentage of elderly, tend to be in poorer health, have fewer physicians, hospitals, and other health resources, and they face worse outcomes and higher risks of death from traumatic injuries. This map shows all of the telehealth sites that are currently on our network. We have a combination of different types of sites. We've got telehealth equipment in hospitals, critical access hospitals and other types of hospitals, clinics, nursing homes, state facilities like Mid-Missouri Mental Health Center and Marshall Rehabilitation Center, and nursing homes, and we've also got equipment at Fort Leonard Wood to help provide specialty care there. This is not a real telehealth encounter. It's a mock picture, but yeah, and that's me in the picture. But this shows an example of sort of what it would look like. So the gentleman on the right side of the picture would be presenting the patient to Dr. Edison, who would be on the TV. And this picture shows what it looks like from Dr. Edison's end. So in the clinic rooms, we've designed the system so that they're non-intrusive and small, because we all know how small those clinic rooms can be. Here are some of the different specialties and different things that we do with the Missouri Telehealth Network. Psychiatry and mental health is by far the largest utilizer of clinical telehealth for the Missouri Telehealth Network. They do about 70% of the live interactive encounters that we have. Dermatology is the next biggest. Sort of in a different category is radiology, teleradiology, which is not live interactive. That was store and forward or asynchronous care on that. And as you can see, there are a lot of other things that we can do over the network, and really we can do anything. It's just limited to the provider and your imagination. So does telehealth help? And how does it help? I guess diagnosing and treating disease early saves money. It saves travel costs for the patients for sure. Expense for transport of captive populations. And we did a study, a cost-saving study for the Marshall Rehabilitation Center, and that showed that each transport saved an average of over $300 per visit to Columbia by seeing them over telehealth. And we also actually found that it provides better care because by seeing them over telehealth, the physician in Columbia can talk to the care provider, the people that take care of those folks on a daily basis, and get better histories, so it does better care. And then home telehealth and remote monitoring keeps patients healthy and at home longer. So telehealth improves quality and access while lowering the cost, and all those things are good things. But about the costs, one of the biggest barriers to implementation of more video conferencing and teleconferencing equipment across the state are the costs of the T1 lines that we require. And those cost right now about $400 to $800 a month per facility. And a lot of, well, really most of the places cannot afford that by themselves. And so I'm going to talk a little bit now about an FCC program that hopes to help with some of those rural health care technology costs. Before I get going on this, I'll give just a little bit of background information on what the FCC does or has tried to do in the past to help with these communication lines. They set up a program that takes advantage of the Universal Service Fund, and that fund is to help discount high-speed lines to rural healthcare facilities. But it didn't really work the way that they wanted it to. They only really spent about, I guess, 10% of the money that they were hoping to discount those lines. So what they came out with this pilot program just this month. And so the goals of the program, the pilot will enhance access to healthcare providers to advanced telecommunications and information services. And it's to help public and nonprofit healthcare providers build state and region-wide broadband networks dedicated to the provision of healthcare services and to connect those networks to Internet 2, which is a dedicated nationwide backbone. So since the existing Rural Healthcare Fund is underutilized, the pilot program will work within the parameters of the existing programs to explore ways in which the Rural Healthcare funding mechanism can best be used to further the goal of enhancing access to advanced telecommunications and information services. So the 2-year pilot program, they're really going to study all the different participants and get a better idea of how to utilize that healthcare fund. In the ruling, it says that all public and nonprofit healthcare providers may apply for funding to construct a dedicated broadband network that connects healthcare providers in a region or a state. And that is a lot the same goal that we have with the Missouri Telehealth Network, which is one network throughout Missouri where any site can connect to any other site for clinical services, preparedness, training, administrative meetings, and educational purposes. I didn't put up a website address for the FCC, but if you just go to the FCC website, it's got that order on there if anybody would like more information on that. So, thanks.
Thank you, Rachel. Now we're going to hear from Karen Thomas.
I have to lower the mic a little bit. Okay, well, okay, here we go. I would like to just say that I appreciate being asked to speak today, and I'm not going to be able to say everything about what we've done with our telemonitoring program, but if you have any questions or if you'd like to learn more, but I do want to take this opportunity to hit the highlights of what we've done. I think everyone knows from what we've talked about today, the real question is we have a lot of people to serve, we have a financial strain, and we have fewer resources. So some people refer to it as a perfect storm. I think everyone knows that this is something that there isn't a magic bullet, and we'll have to address it one issue at a time. So the solution is multifaceted, and what I'd like to talk about today is telemonitoring as just part of the solution. This by no means is the answer to everything, but it is a small part of the solution for those patients who are at home, enabling us to have contact with the patient. My goal today is to discuss the benefit to both the patient, the physician, and the payer, to emphasize that it's really the program, not the equipment, that we want to talk about, and to review some outcomes of our programs. So let's talk about what is telemonitoring. Telemonitoring is a device, FDA-approved device in the home, which enables the patient to monitor their vital signs. That would be blood pressure, weight, heart rate, oxygen saturation, temp. In addition to that, you've got PT-INR, glucose monitoring. You can transfer digital photography, which is often good, often used with wound care, and lung capacity spirometers and peak flow meters. What happens when you're monitoring someone in the home, this information is sent over a telephone line and sent into the office of the monitoring agency. There, they will have identified individual parameters for each patient in their home, approved by their physician, and whenever there is a monitoring done that comes out of those parameters, which is outside those parameters, then there is an alert on that monitoring station, and that patient is called by the nurse doing the monitoring. We monitor 1 to 4 times a day, 7 days a week, nights and weekends included. So that gives us a wonderful opportunity to stay in close contact with that patient. A little bit of history, not so much about what our the size of our agency or what we do there, but I think it's important to know that we've been doing this since August of 2002. We now have 380 telemonitors deployed out to homes of our patients, and from the time we've started, we have monitored approximately 5,000 patients. Some of those patients originally started out as Medicare patients in the post-acute setting from the hospital or after they've gone from SNF to the home, but now we're going to talk about some other patients when we do that. We're currently providing these services in 26 counties in southwest Missouri, and we will be expanding out to 35 counties in the very near future. So that gives you a little bit of idea that we've monitored a number of patients and had some very interesting encounters with those patients. This is actually very well accepted by the patients, even the older patients. The majority of our patients are in their mid-80s, and we've had very, very few patients not comfortable with using this technology. And as we talk about the benefits, I think you'll see why it's been so well received. Karen has asked me to talk today about what are the elements of a successful monitoring program. And when I go through this, I think it's going to resonate of a number of things that we've talked about were other issues that are facing the citizens of Missouri. One of the most important things is we need physician buy-in. This is not a piece of equipment that goes back to a home health agency or a monitoring agency with information, because without being actionable and doing something with it, it has no value. So that's really the key. So this is a collaboration. So it's very important that the physician buys into this process. You have obviously reliable monitoring equipment. You need to have, really the key is having an established clinical program. You need timely interventions. That's why we monitor different times of the day. This is very unique to each patient, and being able to have one nurse at those monitoring stations, or depending on the number of monitors you have out, nurses, you can handle a number of patients and see that they get the attention that they need. When we talk about evidence-based clinical practices or outcomes-based clinical practices, and that's knowing what you do for each intervention, what you do for the different types of patients, and that have proven to provide good clinical outcomes. Communication skills are key. I've heard that discussed time and time again today. That person who is monitoring with the patient really needs to be able to communicate with the patient what we need the patient to do. They need to be able, if necessary, to call the physician and very concisely give the physician that information so that they know it's correct, and we're not taking a lot of extra time. And hopefully, as we go through here, I'll talk about, it's our goal to actually save the physician time when we're communicating that information back to the physician's office. So communication skills are highly needed. Patient education. We've talked about some things today about Don't just assume that because the information is out there that the general public is going to read it and know when they need to use it. This is so key. I think when you look at our outcomes, you'll see that the bulk of the result of those are giving timely education when the person has had a situation that it warrants it. So if it's regarding their blood sugar, you talk about their diet then. So it's very timely with the education, and I've already talked about it's necessary to coordinate with patient, physician, and the agency. We'll go through these very quickly, but our top diagnosis for those patients who work well with this type of monitoring: congestive heart failure, coronary artery disease, COPD, hypertension, and diabetes, and we're now working with the preeclampsia and gestational diabetes. So these are not limited to this, but these patients are well suited for telemonitoring in the home. Now you say to yourself, well, what good does this do, or what have we been able to accomplish with this? And today I'm going to show you 3 different sets of outcomes for different types of patients. The first patient is the managed care patient, the Medicare patient, and I've just compared this to the state averages for ER, emergent care visits, and rehospitalizations while on home health. And you can see right now our state averages are 20 and 26%. For this particular managed care group that we were monitoring, our ER visits were 7% and 15%. So you can see that we were able to keep those down and keep those people out of the ER. Our next group, okay, I think I've skipped one, but we're going to run short on time. The second one is our overall Medicare population. This one is probably one you'll be much more interested in. This is a Medicaid population. These people have chronic illnesses. This is the results of 311 patients. I won't go through all the statistics on getting these results, but the time comparison is for the same time period. These patients were specifically chosen for this project. They have 3 to 5 comorbidities. A number of them were using the ER as their primary care physician. They had been in and out of the hospital. These are not patients that went to the hospital or ER a lot, then had open heart surgery and then didn't go back anymore. So these really were the high utilizers of the system. What we found is that these patients were very receptive they began to buy in and take better care of themselves and know that people were actually working with them to keep them out of those ER. I think in summary, the thing that we need to point out is what were the benefits? To the patient, we have improved clinical outcomes and an improved quality of life. And as I heard numerous people talk about today, this patient was actually involved in their patient care. They started to understand why they were gaining weight, why their blood sugar was high, why it was low. They really started to have a much better knowledge of their disease process and take part and take a little bit of responsibility with their own care. Our patient satisfaction scores, we had 98% of all the people that we've monitored say they were very satisfied, and I think a good part of that is the daily, if necessary, or once or twice a week, contact with a clinician, and it also helped the particularly elderly because they were lonely. So that gets into the depression issue. In summary, the outcomes for our physicians, we had improved clinical outcomes. One of the things that we did was we had improved patient information. How many times has someone gone to physician? The physician said, "How are you today?" They say, "Oh, fine." But they weren't fine that morning, or they weren't fine yesterday. And we make this information available to the physician, fax, email, chart, graphs, any way they like, so they've got that information there. We have higher compliance rates, which obviously both the patient and the physician are looking for, and we've had numerous physicians tell us they have fewer worried calls from the patient or the patient's family after hours. The payer, the summary, the advantages to the payer: fewer hospitalizations and ER visits, lower utilization of healthcare resources, higher patient satisfaction scores. The patient feels that they're being taken care of when monitored, and they feel like they have some involvement in their care. Well, I realize this is very quick, and this is a project that we're very excited about. I will close and let others speak, because I know I'm standing between you and the reception. But in summary, I really think if you have proven telemonitoring equipment, good clinical practices, care coordination, and patient and physician involvement, you will see improved clinical outcomes, improved quality of life, and lower utilization of resources. Thank you.
Thanks, Karen. That was great. And our next speaker is Jim Hansen.
Good afternoon, everyone. As you can tell, I've got two notes, and the first one's obvious. I lost my voice on Wednesday, and I'm trying to get it back, so I will strain, and I apologize for that up front. But if you can't hear me in the back, please raise your hand. And excuse me. And the second piece that I want to tell you is that let's see. Sorry, let me start. I want to thank Karen for inviting me here. I really appreciate that. And the second item that I want to tell you is, as Karen had said in the intro, I'm a brand new employee as of actually next Monday. So I'm not even actually officially employed, and there's a story behind that, and I'm going to tell you that in just a second. But I'm really excited about coming and sharing our story, and I think it'll fold in nicely with what you heard earlier, what Dr. Young was describing in terms of RIOs and health exchange, information exchanges. Let's see. There we go. Real brief overview. What's the goal? The goal is to have an independent third-party agency who facilitates the electronic exchange of information. I'm old enough to have been involved in the CHINs back in the middle 90s, and that was a big problem, is that there wasn't independent. There was also standards. There wasn't the internet, and that really is a huge enabler today. But the purpose of that is, as you can imagine, is to improve care and lower our costs. And the interesting or the unique feature that we have for Healthy Mid-America is that it is sponsored by employers. So it's coming at this at a whole different way than a lot of the other RIOs, and I'll go into a little bit of detail here in a second. So the concept was sort of hatched about 18 months ago as the nation was starting to be a buzz in terms of the RIOs and what the information exchange scenarios would be. And Cerner is one of the largest employers in our community, and we're very lucky to have them, and they're very engaged in healthcare and making progress to move healthcare along. And they started a genesis of, well, what if we brought together and did a community health record, and how would that work, and how would we move forward? Well, rather than take the grant path, the group decided, let's try to engage our local business leaders. Let's try to get some involvement, some community involvement. So they worked through that process a year ago, summer, and then they announced the intent that they're going to form this organization. And then this year, again, the great thing that I'm standing here and I am not even started is that there's a great group of people, both at Cerner and on our board, who have been running this organization and pushing it forward for this whole 18-month period. It's just now we're getting to the point where we want to deploy a pilot, and we're starting to get the technology out into the field, and so that's why I'm here. Some of the key features of what we're talking about. This is a payer-based record, and we talked about that earlier. Dr. Young talked about maybe it wouldn't be actionable. If it's your primary physician and they see you and your records are all there, yeah, it's probably not pretty actionable for that. But if it's in an emergency room situation where you don't know anything about them, or a number of other referral type situations, it has been proven around the country that it is helpful. It's not perfect. Where we want to go is obviously over to the clinical side, but rather than wait 2 or 3 years for that to come, the goal here is to create a mock or a proxy for that until we can do the transition. And what Cerner is doing down in Jacksonville is actually going straight to the clinical information there. So we've got a couple of different models that we're using. And this technology is also being deployed at TennCare that was spoken of earlier. It's really easy. It's web-based. Interops with existing applications because it's a web browser standalone piece at this point. Once the standards, the interface standards get set, then we will work on doing the back-end integration. Until then, the system, Cerner, is interfaced with just about every possible system that there is in healthcare, and so we're going to leverage and have the benefit of that process. And it's a stepping stone, and I think that's where we're at a big major debate in this country is, do we wait for the perfect situation or do we start? And my take is that we start, because we not only want to get the technology out there, but we want to get the people and we want to get the processes changed. And we all know process change takes a lot in it, especially in the healthcare environment. That will take some time. So it's getting everyone moving in that direction, and that's really the genesis for why this approach is being taken. The second piece enables aggregated and both shared-only data. So shared-only would be what the ED doc sees if they looked up the patient. The aggregated, there's two different models or two different philosophies. When I was at First Consulting Group, we started the Patient Safety Institute, and we developed a system that was very much like an ATM, and it allowed you to pull information from various medical facilities and created a virtual record. That strategy is good in terms of getting early buy-in because you're not centralizing data and you don't have all the concerns around that. But what we really want to do is we want to be able to drive the public health and the clinical research as we get into the biomedical pieces. And so the only way to do that is you've got to put that data in one place. And so as you're listening to other RIOs talk about what they're doing, kind of think it in terms of, is it the ATM mode or is it the pull it together in a central repository and report off of it and be able to run some of the public health situations and scenarios that the folks in this room do. What's the benefit for the healthcare? Number one is it's free. Anybody who's been trying to introduce technology, it's very, very difficult in a medical, especially in a smaller practice, to be able to get them to pony up and buy technology, and so they don't need to do that. The cost is being footed by the employers. It empowers them. They do have the real-time viewing, and again, as quick as we get the information in, it'll go into the system. If we get a weekly feed, there may be a delay. If we get a daily feed, the goal is obviously to get to even real-time, even on the claims side. And then supports multiple workflows. Because this application is just a browser-based, it can fit in pretty easily with what folks are doing. And then the e-prescribing module is very interesting because since 80% of physicians don't have EMRs and are not on electronic systems, this allows us to immediately enable the docs with e-prescribing. So we can immediately start going through the formulary issues, cost control. We can start talking about the drug interactions. So it brings that capability immediately to the process. Mentioned TennCare just a few minutes ago. This is a little summary, more detail into what was going on there. 1.1 million Medicaid members. TennCare is the Medicaid plan, if you're not familiar. Bringing in Blue Cross Blue Shield to Tennessee in their commercial life. So over 1.5 million people are now being enabled here in Tennessee. And then so they started at the Medicaid side and then started rolling commercial on side. So Nissan is rolling on top, and then they're looking at Cigna and other ways to go. And I think that's the question, is that a lot of people are trying different approaches, and this is one approach, and what we're doing in Kansas City is a different approach. They've got the data flowing, and I'll tell you, for Kansas City, we've got agreements from the majority of our providers to get the information in, and it covers 100,000 lives, so it's a significant starting out of the gate for us. They're already up to 6,000 clinical users at 1,100 sites, so it's very scalable, very rugged. I took just a couple screen prints here that I thought would be helpful for folks. as you kind of look through this. On the left-hand side, you'll see patient summary, patient demographics, claimed visits. Okay, that's what we're doing. We're not talking about encounters here. We're talking about recreating a proxy, so that's a claimed visit. And then medication, et cetera, down through the lab results. The lab piece, as was talked about earlier, is absolutely critical. I mean, the claim data is going to come in, and it's not going to have it's not going to have those values, obviously. So the idea, like in TennCare, is to have the lab companies interface directly to the system and provide that kind of information into the process. We've got the PBMs that are doing the drug piece, and then we've got the payers that are doing the claimed visit component of that. And some of them will do multiple pieces, but that's one scenario of how that works. So this one just has some generic benefits in terms of if it's coming from a TPA, a third-party administrator, then it's a proxy for their problem list. And the sort of the workflow is as you're getting ready to see your patients the next morning, you create that day list, and so you'll go through and you'll look up and see if any of your patients have this type of information, and if they do, you'll use that to kind of map you through the process. This is the medication and immunization screen, and so there's a lot of color coding that goes on in terms of as it was talked about earlier, in terms of ranges and in terms of so that it's easier to the eye to pull things out. The immunization piece is a little interesting for Healthy Mid-America, in that there's a initiative with the federal government with the state government in Kansas to exchange information on immunization. So we're going to look at that. What are the issues around that in terms of systems, in terms of privacy and security? So we'll be able to read out to this group next year if we're here and be able to tell you how that's going. So the drug interaction, so it's the normal things that you would think that if you had that stuff there. And the last page is the laboratory results, and this is obviously looking at the values and whether it's me as a consumer getting a view of this, or whether I'm the physician or the clinician that's getting a view of this. They're obviously able to make that it can be actionable if it's a referral and maybe they didn't get the paperwork, or until we get referral automation in a lot better place than it is today. This will allow them to maybe get to those. That happens very frequently to me, that I don't get the reference materials, don't get over it, and they have to stop and contact the folks. I mentioned earlier that I'm brand new, so is the organization in terms of a place. One of the cool things about engaging the community is not just to have them write a check, it's to have them take some, get some teeth into it. So many of the companies are providing in-kind services. So we have one of our partners is a real estate company. They're providing some space downtown in Kansas City. We're looking to do the same thing. We've got another one of our partners is doing furniture. So we're getting them involved and getting them engaged in what we're doing. And I think that's another key piece here, is that it's not just about check writing. It's about getting them involved. They came together. They saw that there was a problem. They saw that costs were a big issue, and they wanted to take care of their population and for their employees. And the bigger picture is for Kansas City actually to then be known nationally as one who has systematized the community's processes to a point where that it gives them a competitive advantage for employment. We talked a little bit earlier in terms of Kaiser and Kaiser Permanente and their model. I would suggest that I think in the future, especially since that model is not prevalent in the United States, that what we're really looking at is virtual care chains, and we're really talking about being able to put various pieces together and link those together, look at quality across those, and be able to move information around. And so without a community health record, it's going to be very, very difficult to be able to start to get some of that fluid flow of information that we don't get today when we go about handling our work. And there's my temporary information, and we should have all of this stuff updated in the next month, and we'll be have a real email address and real phone systems.
Thank you very much.
Thanks.
And last but not least, Rick Royer.
Thank you, Dr. Edison, and good afternoon. In true World Series fashion, Dr. Edison told me that I was going to be batting cleanup today, which means you're the last speaker on Friday afternoon. You have to be prepared to fill in the gaps for what all of the rest of our panel speakers didn't talk about. So I did prepare 137 slides, and don't worry, I can wrap it up in about 45 minutes, okay? Now, for something completely different. Let's back up here one. There we are. We want to talk today about what is going on in the state in terms of electronic medical records, electronic health records, and other subjects from a ground level viewpoint. Primaris, who I work for, was incorporated 20-some years ago as the Missouri Patient Care Review Foundation, commonly known as Missouri PRO. And we have been in business since then as the Medicare designated quality improvement organization. Among other things, we work for the federal government. We work on quality and in quality improvement in all medical sectors. You can see we work with all of the medical provider groups in a variety of different areas. Our work is confidential, and our work is free because Medicare pays us to do it. We do a lot of work with Medicare data, so that provides them the platform to do that. What I'm going to talk about here in this respect is physician movement into electronic record keeping from the quality perspective, since that is what we're about, is improving quality. That's what our mission is. And many of the slides that you see are the same slides that individual medical groups, academic practices, medical societies, hospital-based physician systems have seen and are seeing right now throughout the state. So it's something that we're doing right now. What are we going to talk about? Three things, one big, two little. Improving quality through electronic health records and medical records. On our way to Rio, a phrase I coined myself, because we are on our way to Rio, and then some things going on in the hospital industry. Improving quality through EHR, this is where we spend most of our time, and we outline the objectives of what we're about, or what this is about, with the physician practices we're working with. We would identify the goals of quality in the practice setting, discuss the benefits of these things. You know, this thing kind of moves by itself. There. Treatment issues, clinician and patient issues, and then outline the impact of EHR adoption, population care management, things you'll see more slides on in a minute, and then introduce Docket, which is a project that the name of the project we're working on. It was discussed by Dr. Young earlier, and it's very exciting. How this is all set up is the IOM, of course, set up in its report, Crossing the Quality Chasm. Current system really can't do the job. Trying harder will not work. Many years physicians have said, what do you do? Well, I just try harder. And it's really not going to get us where we need to go in terms of managing chronic conditions and patient populations better. Why are there priority areas? Well, there's serious and widespread gaps in quality performance throughout the medical system in the U.S. There are some reports there that have spotlighted these things. In the IOM report, Crossing the Quality Chasm identifies the characteristics of care, and Dr. Edison has been very judicious in reminding me from time to time what they are, and there are these 6 that are just listed there. Quality problems, however, still persist. Poor treatment of diabetes. There are tens of thousands of premature deaths, limb amputations, kidney disease, and blindness going on in the country right now. There is inadequate care after heart attacks, 18,000 deaths per year from inadequate post-MI care, and less than half of adults 50 years of older have recommended screening tests for colorectal cancer, which is the most common cause of cancer in the U.S. Cost of chronic disease is significant, and by 2030 it's going to be worse because almost half of Americans will have a chronic condition, 25% will have multiple conditions, and 4 out of every $5 are spent on people with chronic illnesses today. Why is there interest in this? Stop. Okay. Cost, quality, accountability have driven demand for a change in healthcare. There's lack of recommended services. We don't have a national monitoring system. We often are dealing with obsolete information. The information that Primaris gets, for example, from CMS is often lagged up to a year just because it comes through claims instead of instantaneous. And there's low knowledge to practice penetration. As we mentioned earlier, it takes 17 years to get something from the cutting edge to the bedside in many respects. HIT is an essential component of change because the world is changing much faster than we have been able to keep up. The President issued the executive order establishing the national infrastructure and getting things moving through the National Coordinator's Office. We've certainly talked about that earlier. And this is leading us to the transformation of American medicine. That is, medicine we see will move from a cottage industry to an integrated continuum of care over the next several years. It will be organized and financed globally. That is happening right now. It will be delivered to the people locally by care teams. You heard more emphasis on that today through the telemedicine approach and other approaches that emphasize local impact. And care is enhanced by the internet, information technology, and the EHR utilization. How does CMS, that is my supervisor, approach this? There are four basic strategies they use. One, measuring and reporting performance. Measuring and reporting performance. Two is adopting and effectively using information technology. And this is what we're going to talk about here in a minute, how we roll this out. Three, redesigning care processes. Dr. Young spoke about this at length, in that the actual process of care is very important in terms of how it is impacted by the use of technology. And fourth, changing organizational cultures, without which the other three wouldn't happen. Other industries say some specific things about quality as being reduction of waste and variability with an attention to customer service. This is not a healthcare definition. We brought this from elsewhere. So how do we roll this into the healthcare system? What are the things that we see in the office practice? Here are 7 or 8 different points that we're looking at in the systematic adoption of quality health care via a redesigned system. Office redesign, systematic practice, team-based care, evidence-based medicine, ongoing monitoring, much of which is not possible today without EMRs, as well as adherence to protocols, clinical guidelines, and so forth, and decision support tools. When you talk about the wealth of medical information that's coming out more rapidly every day, every week, it's literally impossible to keep up with the types of things that need to be done without decision support. So this is an oncoming area in the arena. What does IT do? Well, it supports performance measurement, it assists in point-of-care decision-making, and improves the provider-patient interaction. You know, 75% of patients that were surveyed just last year thought that their doctors made use of electronic medical records, when less than 1/3 actually do. The patients just figure, well, the doctors are up with the computer technology, everybody else is, banks, airlines, and so forth. I just assume my doctor was. What is an EHR and why do we work on it? Information technology can play a central role in effectively developing efficient office practice, and the EHR is an emphasis on health. That is a continuum often outside the individual physician's office. Often a little discrepancy between that term and electronic medical record, which can be confined to things that are only captured in a physician or another system. Here are some of the facets of an electronic medical record that we're looking at, including e-scheduling, email communication on a secure basis, DM tools, ordering communication, much of which is now going on. Sorry about this. Electronic clinical practice guidelines, prompts, alerts, and so forth. Big deal in terms of managing chronic populations, e-ordering and e-prescribing. So there's a whole range of things that we're looking at in the electronic medical record world. Well, how does it really support quality? Provides a platform for office redesign. Very important, because this is going to be a way in which this is really sold and does well in the marketplace. E-prescribing and transmission. medication interactions and alert and allergy checking, guidelines and protocols I mentioned, and decision support tools. This is how this really supports the quality platform, which is what we're looking for, is by allowing these things to be done on a more consistent basis without the kind of variation you now see in the system that we have. This allows professionals to monitor the health status of their patients, support their care decisions, expedite referrals, automate and save time for ordering drugs, tests, and so forth, and store and retrieve records in a more effective basis. We got a long way to go. Most solo and small offices still don't use this, and as was mentioned earlier, some financial incentives would be helpful in getting EHR systems rolled out and communicated nationwide. Quality health care, as we'll define it, will be high quality, consistent care outcomes. That can only be achieved by care teams engaging the patient and providing systematic practice on a bedside or functional level. Well, this gets to physicians moving to the improvement phase, which is the last phase you'll see in a minute. And what does that mean? Good question. That means in an improvement, you're really utilizing the reporting functions that are inherent and available in an electronic system. That you're actually reviewing reports and taking action on a rapid cycle basis. You standardize orders and so forth. These lead to you being able to improve your bottom line by economizing on the resources that you expend for you and for your patients, and that you're preparing for pay for performance, something that was not really discussed, probably a subject of a later policy statement or policy format, but it will be here certainly within the next couple of years from the Medicare program, and is already being experimented with in the private sector in a variety of different ways. Docket. Docket is the project that was the name of the project we work on. It means Doctor's Office Quality Dash Information Technology. What is it? It's the term that we use to refer to a program funded by CMS with us. It assists physician's office. All right, one more. Okay, it assists physician's office to transitioning to an EMR. Now it'll get it. By doing several things. We do this in a very standardized format. One is it prepares the practice by doing some analysis of the practice itself. Secondly, we go through and select with physicians and implement with physicians an EMR, an electronic medical record. And third, we then work with them through a multi-year period of time in achieving the full benefits of EMRs to support your core business. By your, remember, this is often directed to physician groups. We now have more than 50 practices in the state of Missouri that are actively working on this process. Most of them are at that very first bullet or the second bullet in there. They're now selecting and stuff. So implementation is key in the next year or two. Here's a screenshot from our website that physicians pick off, asking the different phases of this process. This shows all the way from application, readiness assessment, results of the survey we took statewide, preparing your office for electronic health records, financial considerations, vendor selection. It's a menu of things. We go through it on a very detailed level. Here are the phases of it, and these go on from 2 months to well over a year, with the evaluation and improvement on an ongoing basis, so that physicians know that we're behind them to work on this. Okay, we're gonna move on then to RIOs, because this piece is only a part of a larger puzzle. And a regional health information organization is something we have started talking about in Missouri. There are pieces of it on the ground that are being used in different places right now. And what we would like to see in the next several years is integration and moving forward with this in a systematic way. This provides a framework for health information exchange, because data can then be exchanged among a variety of different players once we have an organization set up to do that. There are a number of different models, the decentralized model, a centralized model, and so forth. So there are different ways to look at this, and there's an issue that I'll get to in a minute that kind of defines where a lot of these go. And what's important about a RIO is that it is a basic building block for a national network. We've outlined a goal of wanting a national network within 10 years. There are a whole bunch of efforts now going underway, but if you look at the way in which it has to be put together, it's easily a 10-year job, but a local RIO, or a regional health information organization, is that basic building block. What are the issues then involved? Many. Privacy, we talked about that earlier. Governance, who's in charge of this thing? Interoperability, what are the standards? Can they talk to each other? Funding, who's going to pay for it on an initial setup basis and then ongoing, all right? Functionality, how's it going to work? Is every component the same? Do medical practices and hospitals have the same level of functionality or not? Data ownership, big deal, major deal as far as who owns the medical records. Does this go to a central repository that then owns it, or does each provider tap into a traffic cop, as someone put it earlier, that actually just routes data around, but each provider group or subcell controls their own? And then lastly, and very importantly, what is the role of the state? And through the Governor's Task Force, we have tried to define or touch on these subjects so that we can have some coherent method of moving forward, knowing that we have a plan in place for what we're doing throughout this. Actions in Missouri, this will be the last slide. I'm not going to touch on the hospital thing. Actions in Missouri, what are we seeing? Here's just a few examples. We talked about, I think, most of these earlier. The task force, the KC-RE, which has been active for the last year, actually exchanging data from different partners within the Kansas City area. KC CareLink, which looks at a chronic disease model within that same area. St. Louis Integrated Health Network we talked about earlier, and the BJC Personal Folders, which is a personal health record, but for a very small group. So as I mentioned earlier, there are pieces on the ground for these different types of things. They're going on at different levels. But what we want to do is proceed on a systematic way to put them together on a larger scale statewide so that we can really get to where we need to go. So that concludes my 45 minutes in only 10, so thank you very much.
I want to thank all the panelists for their great presentations. And I just was sitting there and thinking, does anybody else feel like we're sitting in a time capsule? So this is going to be a video time capsule, and we're going to look back at this day 10 years from now, 20 years from now, and how, we're going to laugh about where we were in terms of health information technology in Missouri. We have time for just a few questions. And everybody's tired, isn't it? And let's get you a microphone. Here comes Nicole.
I was going to say my oldest son is a plastic surgeon, and I can see his use for this. He automatically sends back when insurance company, if he asks them for a certain amount, and they always send 1/3 of what he should get. Then he appeals it. Could he not use this information because they're going to ask for all this information? Could that be used to send to the insurance companies to appeal their decision? Or I know you mentioned that it was confidential.
Anybody want to speak to that?
Well, our work is confidential, and that when we work with you as a doctor, all right, whatever we do with you is private between us. It's like an attorney privilege, a conversation. But the question you're asking is, can the physician electronically supply medical records that would substantiate payment? And that's an allowed transaction under HIPAA. So we would think that that would be allowed. Now, I don't know if we've gone that far, but I don't know why it wouldn't. It would be one of the benefits of being able to do this. You could upload more clinical data very easily to have perhaps speed decisions for payment from the payer standpoint.
Dr. Swearingen, did you have a question?
Hi, I'm Jenny Swearingen. I'm a resident at the University of Missouri in Columbia. And my question's for Ms. Thomas. I just wondered with the telemonitoring, if the patients have a cost for that service or how it's funded?
No, the patients have not paid for this. This is, particularly with the Medicare, this is something that we've provided as an agency. And there is some funding for the Medicaid on a pilot type basis, and so it's of no charge to the patient.
Deb?
If you have Medicaid or Medicare mean, or you say no charge to the patient, you're saying it's billed to Medicare or Medicaid?
It's not billed to Medicare. It's what we have used as our standard of care. So we, as an agency for the Medicare population, have absorbed the cost.
I'm still a little confused. Like a self-pay patient could receive those services and they would be paid for by?
Well, no, if it's a self-pay, then we would try to figure out some charge for it or try to find them some funding. For instance, if they were a Medicaid patient, we have a small pilot for the Medicaid population that we would be able to get some funding for that patient. Chart that I showed you, the 311 patients were Medicaid funded pilot for those results.
A couple of times, I'm sorry.
Go ahead.
I'm Jason Mitchell. I'm a family medicine doc in St. Charles, went through the family medicine program here. A couple of times it was mentioned about using claims data to populate the personal health record or the community health record or the whatever health record we're going to be calling it now. I was a little bit disturbed to see CHR up there now. We don't probably need another acronym. But the experience we've had in St. Charles or St. Louis area with claims data was applied against physicians with UHC doing a preferred provider plan, and we found that a lot of that data was wrong and that it caused more problems than it actually caused benefit. And so I think that it needs to be emphasized that using claims data can bring in some error, can bring in some real problems. It's better than nothing, maybe, but as Dr. Colon kind of mentioned earlier, if you don't know that it's going to do good, maybe you're better off doing nothing. And that would be my comment. The other issue there would be if you're in one insurance plan, okay, but I'm seeing patients who are changing from one insurance company to another as their employers are shifting that, and if they're not all involved, that may create some issues.
But that's exactly what we're trying to solve, because we're going to get at least 2 years back from every payer, so we'll be able to concatenate your picture so that you will get a better picture than what you got. Now, again, if they all came to you and you're the primary physician, it's not going to be that much value. It's going to be more value if you send them to a specialist or some other type of referral where they're not familiar with the situation. But yeah, that's the whole idea, is to make those portable. And in fact, there's legislation being considered, so the health plans will have to make it portable. So when you leave or you switch, there will be records created and moved to your new plan. So there's a lot of activity in that area. But that's exactly what we're trying to do, is get a full picture, not just a payer per year picture.
I'm Jan Swaney, and from Columbia, and spent a couple of years as Chief Medical Officer for Medicaid MC Plus plan. And I wanted to comment on the fact that managed care organizations don't have progress notes available. They have claims data, and they have a strong incentive to manage care. So they're way down the road with trying to use case managers and nurses to try to manage care based on claims data. So I was very familiar with what you were talking about. And you're right, the medical claims data is imperfect. There's a lot to be desired, but the pharmacy claims data is tremendous, and we had it available in real time. It's better than what a physician has in his or her office, because you can always write the prescription, but you don't know that it got filled at the pharmacy. So the pharmacy claims data is terrific in this process.
Great, thanks.
I would say the same thing for the lab data as well, for the exact same reason.
Dr. Fleming?
Yeah, I'm David Fleming. I'm an internist in Columbia. I find it interesting that when we start talking about IT, we seem to migrate back to claims data and migrate away from data of the patient, taking care of the patient. I guess I'm one of those old-fashioned guys that feels that, most of the important information comes from talking to the patient. But my question relates to the question of interoperability, which I agree is perhaps one of the key barriers to really making this system work, or a system like this work. But I think it's more basic than that, and that gets to operability. And that's operability in the office, in the clinic, with that physician, talking to that patient and intervening with that patient. And I think that that's where the key barrier is right now. The vast majority of practicing physicians do not have not only telehealth, but they don't have IT other than for claims data, because they're required to do that in many instances. They don't have a means by which to communicate electronic information about their patients, because they don't have an electronic system. They don't have an EMR. The reason they don't have an EMR is because, number one, it's very expensive. It's $30,000 or $40,000 to set up an effective EMR system in their clinic. And number two, many view it as a barrier to their patient. They view it as a barrier between them and the patient, and they fear it, as sometimes do their patients. How do we get beyond that? I use an EMR. And let me just tell you how I use it, because our system at the University of Missouri is partially effective. I use it by printing out the last note that I had on the patient, and I ask my nurse to do that before I see the patient, so that when I walk into the room, I don't have a paper chart, I have a paper note. And that guides my discussion with the patient based on my last intervention, so I'm talking to the patient and not to the computer screen, which often happens when I have to start retrieving data. How do we get beyond that? And I think perhaps the two gentlemen on the left are perhaps more effective in being able to address that issue, because I think that's truly a barrier at the practice level, at the grassroots level.
Take a shot.
Yes. Well, I think that's a really good point, because not only the functionality of the system itself, that is, how does it work in the office for the clinicians, but how does it aid the practice in treating the patient better from the patient's eyes, is one of the key things that we put as an issue we have to work on. How we're working on this through our rollout of electronic technology in the offices is spending a lot of educational time with the individual office staff, so that they understand fully how to work with these things with the patients. And then we have involved focus groups of patients themselves in doing mock-ups of, what do you think when you go into a room and you see a doctor with a computer screen? How does this affect your interaction with them? So they're trying to get data from the marketplace itself. Admittedly, this is where this is first-generation stuff, because we hadn't done this before. But we think that's the only way we can really learn from the patients themselves. People will quote studies that say there is a correlation between improved patient satisfaction and the use of computers or in the use of the technology, because the patients think you should be doing it already. But we're in field testing that. We often find variability, in fact, in that response, and that not everybody is aboard with that. So we're working on those barriers with the office staff, with the patients directly, to the extent we can.
I'd also comment from a just general IT perspective. If you look at software design from 15 years ago, I mean, the stuff is virtually useless, and the user interface is just terrible. The functionality is not there. I think it's just part of the maturity process that as these systems become more widely used and there's more information available about what does and does not work, that's going to get integrated in, and that's where it's going to be critical for the Cerners and other vendors in the world to really focus on usability and integration into the practice.
Well said. I think that'll be our last word, actually. Our networking reception is in the Carnegie Room.
Yes.
Do you know where that is?
It's right around the corner out here next to the restaurant. And the good news for all of you that stuck through the whole day is that we're going to start the reception right now, as soon as we release you. So you've earned it, and you'll have your drinks available to you.
Just a couple of reminders. Please don't forget to fill out your evaluation form, and we're particularly interested in ideas for the summit for next year. We'd like to be responsive to that. And if you're interested in receiving copies of presentations that are not in your packet, please sign up out at the desk, and we'll make sure we get those to you. And it will all be on the web after November 8th that you can view or download. So.
And as a last note, perhaps we could take a minute and thank a number of people that helped us pull this off. In particular, Pat Hubbs, who does all the logistical coordination of this. So, Pat, you're tremendous, and we love you, and we couldn't do it without you. But the whole team as well. Shirley Walters works with Pat, and then our team of Gwen Rodeman and Stan Hudson at the Center for Health Policy are there for resources for us and for you, and we work together as a team. And then our students and other staff members, Megan Madden and Nicole White and Aaron Haslig. So thanks again for all your help. And
Rhonda Forrest for coming and helping today,
Yes,
and
thank you,
Shirley
Rhonda.
Walters and everybody else. So, okay.
Very good.